Call upon Dr. Anand Rajendran, Head of Vitreo-Retinal Services at Aravind Eye Hospital, Chennai, to give his talk on multicolor fundus imaging in decision-making in macular surgeries.
Good morning, everybody. I'd like to thank Dr. Dhanashree and Dr. Pramod Bende for inviting me at this wonderful symposium and congratulate the entire SN team for putting together a fantastic program. So it's my pleasure today to talk to you about multicolor fundus imaging in decision-making in macular surgeries. So the principles, multicolor versus conventional erstwhile color fundus photography. So in conventional fundus cameras, the entire retina is exposed to a bright white flash of light, which is essentially broad spectrum. Unfortunately, scattered light is also captured, and that results quite often in a blurry image, with the pupil diameter being the major limiting effect. Whereas with multicolor imaging, it's an SLO-based laser-generated scan with 3 component wavelengths, blue, green, and infrared. And the confocal technology, as we know, captures this reflected light through a pinhole. And the image, therefore, is less affected by reflected light, and pupil size is less of an issue. And the resultant image is very often a high-quality, high-contrast one. So with the simultaneous scanning of the different component wavelengths, with infrared at 815 to 820 nanometers, you're able to look at deep tissue, the outer retina, the RP. With green, laser coming in at 514 to 518 nanometers, good for looking at intraretinal structures, specifically vasculature. And with the blue at 486 to 488, a good study of the vitreomacular interface pathology is possible. In macular surgeries, what are the kind of decisions that we need to make, kind of pre-operatively? Primarily, whether to operate or not. And then, if you do operate, when to operate? Urgent, semi-urgent, or not urgent? Critically, how to operate? Where to begin that peel? And that is a critical question. Whether manual vitrectomy is sufficient or bimanual is mandated. And when you're doing especially diabetic vitrectomies, how to plan that dissection roadmap, how to approach the lines of attack. And with MCI, we know it's a great teaching aid. So personally, I think for ERMs and macular pucker, MCI is a great tool. It gives you a better impression of the ERM morphology and the extent with accurate delineation of the ERM margin, the thickness, the retinal folds. And in a way, it is digital staining. It provides 3D multicolor rendering of the OCT image. The membrane is visible as a green-yellow structure against a reddish retinal background instead of the conventional gray and white. So the key issues and value of MCI for ERMs. Now, when you look at the conventional imaging modalities, fundus photography and OCT, there are certain drawbacks. With fundus photo, this sometimes limited info about the exact margins, the thickness, landscapes, because of the lower contrast and resolution, and it's a little more dependent on media clarity. OCT is great, it's our backbone in our imaging armamentarium, but these are cross-sectional image, and they actually really differ from that en-face view which we surgeons need to have, for intraop viewing. Whereas MCI, like as I said, it's high contrast, reduced light scatter, but the en-face images that it gives you is more relatable to the surgeon's view. And as I said earlier, it's great definition of the contours. So putting all that together, MCI offers you great instantaneous rapid assessment and insights towards ERM surgery. Now there's a lot of consensus in literature about the value and the superiority of MCI over color fundus photography for detecting and characterizing these ERMs. I like this particular paper by Zhang et al. Titled Multicolor SLO Strengthens Surgeons' Preoperative Decision Making and Intraoperative Performance on ERMs. So they looked at, and they kind of, concluded 4 particular things. That pre-op MCI was far better than color fundus photography when you're trying to look at a visual reference of the ERM delineation, and very critically, the selection of that initial grasping location when you start the peel. Intraoperatively, it shortens the duration of ERM peeling, lesser iatrogenic tears were reported, reduced use of dyes was also suggested, no real significant difference in the final visual outcome. It also helps in shortening the learning curve for residents and aids pre-op surgical planning. So as you can see here, the MCI identifies the ERM edges better than the color fundus photography and helps facilitate that first pick, which is so critical. It also helps identify the ERM extent better and then lets you know how much, to peel, the extent of the peel. Also, this was an interesting component where they had masked independent graders suggesting the first point of pick of that ERM based on the MCI versus color fundus photography, as you see in the 2 panels. And they used the surgeon, based on his intraoperative OCT experience, was able to deliver a verdict. And they found that MCI was way more accurate than color fundus photography in predicting the best area to begin the ERM peel. Philippicis showed that the preoperative ERM morphology on blue reflectance was visualized similar to the intraoperative digital image after blue staining of the ERM, as you see in these two images, and that integration of MCI, they suggested further, could enhance surgical precision and reduce perhaps dependence or use of dyes. Again, value add. So this is an image of EM with the component wavelengths, which shows that the blue and the green reflectance are more or less similar and useful, far better than the IR image. If you want to look at ERM pathology or structure, perhaps the blue reflectance gives you a little more. But the green reflectance is great for looking at the effect of the ERM on the retina or the retinal folds, which actually shows up marginally better on the green reflectance. Now, just a case in point, you can see an ERM there. Instinctively, you know that that upper margin is where perhaps you should begin your peel, and the OCT corroborates that. You can see that a little outfold pouch there. The inferior margin also looks tempting. Perhaps you can pick it out there at that lower margin here. But the OCT shows you that this is where the ERM is thin and embraces the retina, and perhaps you could potentially create retinal trauma there. And once that ERM is removed, you can see those retinal folds settle down very well, and even background pathology, the drusens show up much better once those folds settle out. You can also see that crenated downfill showing up. So the cheesy ERM of Chirpy also shows up very well on multicolor, as you can see the inner retinal disorganization, the relative sparing of the outer nuclear layer, and it shows up much better than the color fundus photograph, as you can appreciate. An important question we began with, where surgery is not mandated. You can see here in ERM with a foveal scar, that yellowish-green central location, and you know that instinctively that if you try to peel this very aggressively, you could end up ripping up that fovea. Also, you can see that it shows up ERM with macular ischemia. You can see the vascular sclerosis temporally and the degeneration. Diabetic vitrectomies, MCI can occasionally give you great insights. You can see here on the top left the MCI image, which shows beautifully the fibrosed hyaloid and the green areas, and you can see the vascular nets out here and the avascular areas, and you can see these hyaloidal openings too, and you can take advantage of them. You can see all this is much better than what the fundus image is giving you in the center, and you can plan your dissection roadmap, use that hyaloidal openings to initiate the dissection lines of attack, skipping past or navigating past vascular areas and proceeding perhaps like this from the hyaloidal openings in this direction, and then you can get a good result. We can see post-vitrectomy. You can even image through that silicone oil very well. And these are examples like the case on the left. You can see the bulging hyaloid with the greenish phase. You can plan your unimanual vitrectomy should be feasible here with the right. The case on the right, you probably need to do bimanual, and you see good results post-operatively. The macular hole helps, the MCI helps, it helps the surgeon decide. You can pick out those ERMs, and you can decide that you need to do ERM peeling in cases like this. And especially if the hole size is large, as in a case like this, you probably need to resort to inverse ILM peeling. Now, we've been talking about blue and green images. Does the IR image also help? Now, if you look at these two cases, you know that there's a macular defect, there's a macular hole. And perhaps the case on top is a full thickness hole. But you're still thinking, when you look at the blue and green reflectance, it doesn't give you much. But on the infrared, you see a nice punched out defect there, which is not seen on the lower panel. And you know that you're probably dealing with a full thickness defect in the case above, and that is corroborated on the OCT. Optic disc maculopathy is better delineation of the SRF with the serous RD seen in the greenish component, as you can see here. Retinal stripe picked out beautifully by MCI. Importantly, the foveal thinning shows up as a reddish hue, and looking at this extent, it kind of suggests that perhaps this is the case where you need to do a fovea-sparing ILMP, so therefore it helps your decision-making process. And as you can see, post-surgery, vitrectomy, ILM peel and gas, resolution of that serous RD with restoration from green to red of that macular hue. Also, the crenated contour are seen much better on the MCI than on the fundus photo. Now, it's not all hunky-dory with multi-color imaging. MCI has certain disadvantages, slightly longer fixation period to capture those three separate images. Ghost maculopathy or artifacts come in, and that is usually seen when people do 55-degree MCI images. So therefore, most of the images you'll see are 30-degree, and this is generally how things are. There are color distortions. It is pseudo-color there is a learning curve. All said and done, fundus photography is true color. That's a great advantage. And there is an overlap in the presentation of pigment, hemorrhages, and scars. So in conclusion, MCI does offer significant advantages to the operating surgeon: clearer, sharper image, greater contrast and resolution, better delineation therefore of the pathology extent, and that's where it really scores over fundus photography. By virtue of being an en-face image, it's more relatable to the surgeon. It's a true reflection of the intraoperative scenario in comparison to that, to the structural OCT. Specific surgical USPs helps decide which pointer points to make that initial VR interface surgical intervention or PIC, which is so important, helps define lines of attack or dissection roadmaps, as we've seen, can help you decide between unimanual and bimanual straight away, and it's very valuable as a teaching aid. It's a great screening tool. Because of the sharp images, it lends itself very well to futuristic AI-based screening models. And importantly, it reduces the need for additional imaging with fundus photography, part of a one-stop imaging modality or station, and that is a serious value add in a busy clinic today. Thank you.
Thank you, Dr. Anand Rajendran, for a very colorful presentation on multicolor imaging for macular surgeries.